Welcome to Single Payer Radio. I'm Paul Hoppy, broadcasting from the Hayburn Building in Louisville on the WFMP 106.5 Forward Radio Community Network, where news, information, and entertainment is available 24 hours a day, 7 days a week. The views and opinions expressed on our show are those of the speakers and not the station. Single Payer Radio is a project of Kentuckians for Single Payer Healthcare in conjunction with Physicians for a National Health Program through its Kentucky chapter. We produce this program because we believe healthcare is a human right. We advocate for a national, not-for-profit, publicly funded single-payer healthcare system, also known as Enhanced Medicare for All, covering dental, vision, hearing, prescriptions, mental health, and long-term care, covering everyone starting at birth. Catch our programs at 2 p.m. Monday, 7 a.m. Tuesday, and 11 a.m. on Wednesday. We also stream our show on SoundCloud, Apple Podcasts, and others so you can listen anytime. And remember, this is an all-volunteer radio station and relies on your ideas and donations to keep us on the air. With rent and other expenses, it costs about $42 a day to operate the station. We do not accept corporate or grant money, and our only revenue stream is from the grassroots donations that you guys send us. So if you're feeling generous, please go to forwardradio.org where you can send us a donation. No matter how large or small, it is deeply appreciated. Today, Doctors Mike Flynn and Jean Shively join me as co-hosts with their special guest. So let's get started. Dr. Flynn?
All right, so this is Michael Flynn, a retired surgical oncologist from the University of Louisville Surgery Department. Let me begin with the usual disclaimer. The comments that I make during this program represent my personal views and do not represent the views of the Department of Surgery or the University of Louisville. Gene?
I'm Eugene Shively. I'm a retired general surgeon in Campbellsville, Kentucky. What I say is those of my own opinion and not those of Taylor Regional Hospital nor the Department of Surgery at the University of Louisville.
Well, our topic today is Medicaid and the impact of the so-called Big Beautiful Bill that Congress in its ideologic wisdom passed, which extends the tax cuts in the first Trump administration, mostly benefiting the very rich and corporations, and would fund that by basically defunding Medicaid, a healthcare program that covers 80 million people in this country. So we have two special guests today. Amber, a Medicaid recipient, and Barbara Casper, a retired physician from the medical department of the University of Louisville, who has spent most of her career treating Medicaid patients and similar patients seen at U of L with some serious financial issues. So as we've done with our guests in the past, we're going to give you both an opportunity to make whatever comments you'd like to make for as long as you'd like to make them. And then Jean will begin with the first question. And so Amber, we'll let you go first.
Okay, thank you. My name is Amber, and I have, as he said, I am a Medicaid recipient. I have several chronic health conditions which limit my ability to work and to live a quality life. But I have great concerns about the future, not only for myself, because obviously heart failure and the lack of thyroid has got me on borrowed time, but I worry about people, especially those with disabilities, who are dependent on Medicaid, and the cuts that are going on right now and the measures that people are trying to make it harder for people to access health care are of great concern to me. So that's why I'm here today.
Barbara?
Yes, I'm Barbara Casper, as Mike said. Again, even though I was affiliated with the University of Louisville, this everything I say is not is my own opinion and not at all reflective of theirs. As Michael said, I did take care of patients for 35 years, most of whom were low income. What I saw was a major difference when we expanded Medicaid in Kentucky between the health of my patients before and after and their ability to get care. And so for me, this is incredibly alarming that we might actually withdraw some of that capability to the patients. And I know what happens when they don't have access to care because I lived through that for most of my career, actually. So I am actually appalled at what they're suggesting. And it should be noted that even our state has come up with a bill that is even a little bit more draconian than what the big beautiful bill says. So I'm really worried that patients like Amber will not be able to get the care that they need.
Let me make a quick comment before I turn this over to Gene. When the first Governor Beshear expanded Medicaid in Kentucky, and Barbara, you may or may not have experienced this, the non-paying patients at U of L Hospital went from 20% down to 5%, which was a huge change and really improved the access to health care of this population in Kentucky. Gene, you want to begin with the first with conversation?
Yes, sir. I would like to ask what percentage of Kentuckians are on Medicaid and how that breaks down between rural and urban. And then, Barbara, could you tell us a little bit what happens to a patient if they don't have Medicaid and how that affects their health and their ability to get medical care?
Sure. About a third of Kentuckians are actually on Medicaid, including children and adults. So that's a significant number of people, obviously. And as far as children are concerned, it's about 40 to 59%. It also should be noted that about half of births in Kentucky are paid for by Medicaid. So that's a significant number of people that if they lose their insurance, that will be at risk for not getting appropriate medical care. So aside from that, it should be noted that over 55% of people who are on Medicaid work. So there's a misconception that these people are sitting at home and doing nothing, and that's absolutely not true. So what will happen to them is what happened to them prior to the expansion of Medicaid. And how it was expanded was it included working age adults from 19 to 64 who previously were not eligible for Medicaid unless they were disabled or had some other defining features. So it was a huge number of people that became actually insured by Medicaid. And prior to having that access, I can tell you from personal experience, people did not get the care they needed. They didn't take their medications. They just couldn't afford it. And so that's going to be a major issue for the health of Kentucky, which, by the way, is on the lower end of this of ratings in the United States as far as our overall health.
Let me ask you both to kind of step back just a little bit so that we can give our listeners kind of an understanding of what we all understand Medicaid because we've dealt with it in different ways. Most of our listeners are not medical people and don't know that. So maybe if Amber, we could have you and then Barbara both kind of explain Medicaid, if you like, from both of your perspectives to give our listeners a kind of an understanding of what this program, the details of it is, as well as we can without making it too complicated. So
Sure.
Amber, why don't you start, and then when you're done, we'll let Barbara do the same thing, because I think it really is helpful to have the perspective of a recipient and a provider in dealing with this. This is fairly complicated issue.
Yeah. So I guess I'm going to kind of just touch on a few of the things that Barbara brought up. One of those was the fact that so many people on Medicaid actually work. I was cleaning hotel rooms in Pennsylvania. I was making $9 an hour doing so. And the ladies that worked, I was a supervisor. The ladies that worked under me were making $8 an hour. All of us pretty much were on Medicaid. You know, at the time, I didn't have quite the chronic health issues that I have today, but I did. I had my thyroid surgery, a complete thyroidectomy in 2007. So I was at that time dependent on having medications. If I don't have these medications, they say that I will actually end up in a coma. It does cause organ failure, and that is probably caused. I went several periods of about 6 months at a go where I didn't have the medications, which has probably caused some of the heart issues that I have today when I was not able to get Medicaid. But 49.8% of employers nationally, in Kentucky similar, don't offer health insurance benefits to full-time employees. And I don't think people realize that. I saw one article in the Kentucky Lantern where Andy Barr had said, oh, well, we want people to, get to work, get these good paying private sector jobs, and they can have their own private insurance. Well, that's lovely, but it's not reality because 50% of employers don't offer health insurance benefits, including the hotel that I worked at and several other jobs that I have had over the years. The uninsured rate, you were talking about the amount of money that Louisville Hospital, after they expanded Medicaid, the uninsured rate in Kentucky prior to the expansion was around 14.5% in 2013. That dropped to 5.6% following the adoption of the ACA. There's a lot of people that fell through the cracks on that. So I guess the point that I want to make is that there's a lot of people out there who say, oh, well, these people just need to get a job and then they can get insurance. That's not the case. There are a lot of people, the majority of Medicaid recipients, who actually do work, but their employers choose not to actually offer medical care. So,
Barbara?
So just to kind of expand that a little bit, in order to qualify for Medicaid, you have to make 138% or less of the poverty line. So that actually translates into, for a single person, $22,025 a year. And in Kentucky, the minimum wage is $7.25. And if you're paid minimum wage and work 40 hours a week, you're making $15,000 a year. So just to reiterate that working people fall under this situation because they aren't paid wages that account for that. And those people that are just above the poverty line, like make 140% or 145%. As you can imagine, that's not a lot of money. And so those people were funneled into the ACA, and they had to buy their insurance through that if they weren't insured through their employer through that mechanism. And they've made that harder and much more expensive. So a lot of people who are just over the poverty line are now uninsured again because of that.
I keep hearing from my friends that when I would discuss this issue, there are a lot of people out there who are able-bodied and that can work and are not working. Does anybody have any idea how many people like that are on Medicaid?
Not very many. As Amber alluded to, there are about half people actually work, and there's other people that don't work. They're either disabled, they are caregivers, so they may be caregivers of children, or they may be caregivers of elderly parents, and then they're students. So the percentage of people who are just sitting at home and doing nothing and have Medicaid is pretty darn low. And that my experience with taking care of these patients really reflected that. I did not see people that were able-bodied that weren't working. So I'm sure there are some, as in any system, there are going to be some people that just don't do, but the proposals to have work requirements, first of all, as we said, most people work, or a lot of the people work. And if they don't, they have other reasons why they can't work. But the administration of trying to keep track of all that is going to add a lot of cost to Medicaid in the future, because trying to have people that actually monitor that. Plus, it will mean that a lot of people who can't keep up with the paperwork will actually lose their insurance.
Now, the state of
Well,
Arkansas did something like this with the work requirements some years ago, and my understanding is a lot of people lost their Medicaid coverage. 90% of them were eligible, but they couldn't keep up with all the administrative hassle of getting a postcard to whatever address that the state had, because they run the Medicaid, and then they'd have to respond. And these are people that may or may not have cars, may or may not have computers, may not even have telephones, and they just got a whole bunch of people off Medicaid, and the administrative costs wasn't worth the hassle of doing that.
Yeah, actually, the administrative cost was more than what they say by cutting those people who are able-bodied off the list.
Now, Jay, you're down there in Campbellsville, so could you make some comments about the impact of Medicaid on rural hospitals, how it keeps them going, and what the impact of the sort of big, beautiful bill? I'm not going to use some four-letter words to describe what I think about that bill.
Well, so there was a study done last year based on Medicaid data, cost reports from 2024, and it was estimated that 35 hospitals would close because of a decrease in Medicaid. The hospital here in Campbellsville, the administrator told me we could probably squeak by maybe a 1% margin. So we're talking about a large percentage of hospitals that would close. Not only is this a problem with patient care, but it's an economic problem because a lot of rural hospitals hire a lot of people. They may be the second or third largest employer in the county. So we got a double whammy with economic problems. The other problem that's becoming a big issue is OB. Most rural hospitals are having lots of trouble providing obstetric services. Most of the deliveries in rural hospitals are Medicaid. Medicaid doesn't even pay the cost. It's hard to get obstetrics in the rural community, and so there are a lot of OB deserts in Kentucky, particularly in eastern Kentucky and Appalachia.
Well, Joy, how much of that is a consequence of the anti-abortion legislation that this state has passed? Because we had Ernie and Una Marshall on here for a program a year or so ago, and they felt a lot of that. The maternity deserts are a consequence of this anti-abortion legislation.
I think that's probably a significant issue, and also nationally, people just from the standpoint of attracting residents to training programs. People who are going into obstetrics are not choosing to train in states that have really strict abortion laws, and that decreases the pool of people that you can pull from, and also the people that will stay. I mean, a lot of times people stay where they train, And so that's a problem too, because my understanding is that obstetricians are leaving the state because of the issues with the abortion laws.
Now,
So-
Barbara, you mentioned the bill in the Kentucky legislature, which is Bill 2,
Right.
which adds work requirements and co-pays and other administrative hassles. Will you make a few more comments about that? And Amber, if you are aware of that as well, maybe you could do the same.
Yes, I'd love to. Thank you.
Yes, so what I would say is that I don't know why they decided to have this bill, which actually will hasten the effects of the big, beautiful bill. It pretty much mimics what's in that bill, with the exception of having some, what was I going to say, the co-pays that people are going to have to pay. And I know it sounds like, okay, it's $5 copay, but I'm telling you that people, $5 makes a huge difference. And if someone, for example, has cancer, they require multiple visits to manage their cancer, and that $5 can add up over a month's time. And it is not, I mean, it's no lie to say that people ration their insulin. They, don't take their medication so that they can feed their children. So this is really just adding an extra layer. I believe during the Bevin administration, they attempted to do this as well, and it either didn't pass or it actually fizzled because they realized the cost of administering it outweighed any benefit from collecting copays from patients. So. And Amber, I'm sure you have some comments on this too.
I do. Actually, I called this morning about HB2 because I received an alert to call. So they're not going to hear about it today. Apparently, it's been tabled till next week. I just wanted to, I've talked a little bit about my health issues. So I have no thyroid. I had thyroid cancer, had to have a complete thyroidectomy and have all the lovely side effects of that. Also, I have the heart condition. But just as an example, so first off, it's not necessarily going to be $5. The way that it's written currently, it can be up to $35 per service. So I decided I wanted to tell people a little bit about what that means dollar-wise for me. So I have no thyroid. I have to go, if everything's going well, I have to go see an endocrinologist every 3 months to have my blood work done. My blood work is a mess. It always has been since I had this procedure done back when I was 37 years old. And an office visit will cost me $35. The blood work will cost me $35. And typically, because mine's kind of a mess, I end up with either a follow-up call or another office visit to follow up, which will be another $35. This is going to be approximately $105 every 3 months just to deal with my one medical issue. One. I have other ones I have to deal with as well. I have skin cancer problems that I have dealt with since I was in my 20s. Genetic. I have heart failure. That means I have a cardiologist that I have to see regularly. I have a general practitioner that I have to see regularly. So all of these things are going to be ding, 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 ding. Where is the money going to come? I mean, I can't work because of all the health problems that I have as it is. I don't drive because I take 13 different medications, many of which cause dizziness and other problems. So, I mean, when did the government decide that it was fun to punish people for having cancer related to chronic health conditions? When did the government decide that it was going to benefit society to punish the poor? And I just, to these people in the legislature, $35 is probably the amount they spend on their lunch every day. But for somebody like me, that's a bag of groceries, an entire bag of groceries that will last me about a week. So, I'd like to see them try to live on that.
Amber, let me make a comment about that. And Gene probably remembers there was a general surgeon in Louisville, this is about 20 years ago, who had some eye issues and had to retire from practice, and he ran for a seat in the legislature and became in the House of Representatives in one of the Eastern Louisville districts. And he gave a talk at the Louisville Surgical Society, and he made two very, very strong points, which I've always remembered. And one was the thing we've heard many times before, that making laws is like making sausage. But the other thing that he was very, very clear about was that the politicians do not understand healthcare.
No.
They run businesses, they're lawyers, they're accountants, they do a whole bunch of different things, and he was just so clear about that. That's what we're dealing with, Amber, and
Yes.
unfortunately, I pound my head against the wall when I think about some of the laws that they're coming up with. I don't understand it either.
No. Well, and I didn't get into it because I think I've done it before, either with you or sometimes I have some memory issues. But the paperwork requirements, I don't drive. So, having to run around to get all the paperwork is not easy. I have to get somebody to actually drive me around to collect these things. The other issue is that the new requirement where you have to prove that you're disabled has caused all kinds of issues. I see a lot of people falling off because of that. The clinic here that actually in Bowling Green that I used to see them, I actually changed because of their new policy. They are no longer allowing their doctors to write letters saying that people can't work unless they have legally been declared as disabled. So my doctor was unable, because the administration at the clinic here was not going to allow her to continue to write letters for me saying that I was unable to work due to all my health conditions. So I had to get my letter this time from my social worker, and she was willing to write the letter. But the hospital, and I noticed when I went to one of my specialists recently that their clinic has decided that they're going to start charging people for actually filling out the forms and writing the letters, which, I understand the doctor, it's time, it's billable time. But again, you're creating a nightmare for people that I just don't know how people are going to be able to manage this.
Gene, you live
Yes.
down there. I've asked you this question before, but I'm going to ask you again. You've just heard what Amber said, and what I don't understand, and maybe you can help me out because you live there in the rural Kentucky. What is in the heads of people going to the voting booth and putting these politicians in office there's a Republican supermajority in the legislature, and they're doing just what I said before. They're putting out bills that are against the health interest of the people they represent.
Well, this is a complex issue. I think there's several answers to this. These may not be the exact reason. I don't know if anybody's actually done a scientific study, but in my opinion, there are several issues. One is the abortion issue. Two is the Second Amendment issue. Three is big government. People don't that they don't want big government. And I think in the last election, there were some things that happened on the Democratic side, pushing some issues about gender that just was gut-wrenching to some of the conservative members. That was more important to them than their economic things. For example, I have a member of my Sunday school class, if you bring up some of these issues, it's not just a vocal opposition to it. It's a gut-wrenching, really nauseating thing for him. If you bring up these issues of transgender and homosexuality and those issues, I think there are probably some other issues. There are a lot of people who don't vote who should vote, and then I think there's another issue that I just realized in the last year or two. I think there are a lot of people in rural Kentucky that are actually living fairly well, but if you statistically look at their income, their Social Security, they may have a small pension, it's below the poverty line, but they still own farms, they still have cattle, they're grazing crops and gardens, and they're actually living pretty well. But it doesn't show up on their income. So I think those are the reasons. I like to bring up one other issue that Barbara brought up about OBGYN. I think the reason that OBGYN are not staying in Kentucky is not abortion actually itself. It's a complication of normal pregnancy. For example, if you have a second trimester with a ruptured membranes, the obstetricians can't take care of this because if they go ahead and abort the baby, that's considered an illegal abortion. And so a lot of those patients are being sent out of state. And universities won't take care of them because they're afraid of the malpractice. And the malpractice issue is also a big issue. You know, you can get sued 18 years later because of a problem with a kid. And these combinations of issues of forcing people out of the state in OB, and most obstetricians are not willing to take this type of risk, which is life-changing and can destroy your reputation and your whole practice.
Barbara, you got some thoughts about that? I know this is not Medicaid, but it is Medicaid as well. But the issue of the practice of obstetrics and gynecology, dealing with all of those issues.
I would totally agree with Jean. I think it's not so much elective abortion issues for the obstetricians, but it is being able to provide appropriate care, medical care for a woman with a complicated pregnancy. And that's been going, I believe, actually, aside from malpractice, I think that if theoretically, if they performed an abortion and there was still a heartbeat, they could be charged with murder, the obstetrician. So there are some humongous legal ramifications potentially. I don't know that that's happened in Kentucky, but I think in Texas there was a physician who was charged with some sort of legal, I don't know if it was murder or manslaughter, because a complicated pregnancy and terminated that pregnancy to save the life of the woman. So it's multifactorial, but it is really difficult to get people to practice in that environment.
Well, let's kind of change direction just a little bit and maybe get you all to talk about something that we may not all be very familiar with, because one of the other impacts, at least my understanding, of the defunding of Medicaid is going to be the effect on nursing homes, which has got a large population of elderly people who don't have their resources, and they're relying on sometimes their Medicare, Medicaid component recipients, and maybe we could get Barbara and Amber to talk about that a little bit later. But what are your thoughts about the nursing home issues in not just in Kentucky but in the country if these issues don't get changed with the midterms and maybe the 28 elections?
Well, I'm very worried about it. For me personally, I don't have children, So as my health continues to deteriorate, I'm looking at being in a nursing home. That's the only option I'm going to have. And, one of the requirements that nobody has mentioned, but you probably should know, to receive Medicaid, you cannot have assets more than $2,000. So you can't have a retirement account. You can't have a IRA or any of these other, investment vehicles. So, anybody who's on Medicaid doesn't have a fallback plan. So if they cut the funding for this, these people are going to end up on the streets. I have been homeless as an older woman, and I will tell you, it is just outright dangerous. One of my friends, when I was homeless, she was 64, and she actually lost everything as a caregiver for her mother because she was trying to take care of her mother. And so she had to quit working, which is what prompted everything with her becoming homeless. We're going to have a lot of homelessness with our elders, and this is going to be dangerous for them. I mean, not just the medical care that they're not going to be receiving, but, the actual life on a street is extremely dangerous for these folks. And I don't think people realize that.
Barbara?
Yeah, and in this country, 60% of nursing home beds, now this doesn't include assisted living, et cetera, but of the nursing home beds are Medicaid beds. And so what that means is 60% of the patients are covered by Medicaid, and Amber is correct. If you have any assets as an older person and need to go to a nursing home, you'd have to do what they call a Medicaid spin down, which means that you basically divest yourself of all of your assets other than about $2,000. So people have had to sell their homes and use that money, the proceeds, to do things. It's pretty arduous. So two things could happen. One is, yes, the patients, if there's no Medicaid coverage for the nursing home beds, what happens to those patients? And some of them are so infirm, there's no way they could actually go on the street and get food. Or, I mean, not that I want anybody on the street, but they literally could not physically do that. And families can't necessarily accommodate that. The other thing that will happen is nursing homes will close. And so I've know a nursing home administrator here in Louisville who has told me that they're very concerned about what the economic impact is going to be of the Medicaid cuts on their ability to provide nursing care for patients. So I think people forget a lot of the money in Medicaid is actually spent on elderly people for this reason. So we are, as a country, I feel like this is a moral issue. We need to make a decision about how we treat those people who aren't, rich and wealthy. And by the way, we are spending billions of dollars every day on a war that I don't know who wanted it, but somebody did. So we do have the money, we just don't have the will to actually take care of patients here.
Yeah, we are spending $1 billion a day to finance this war. It's crazy.
Barbara, we were talking about the poor and the working poor in terms of going to nursing homes, but this affects people who would normally consider themselves middle class because typically if you go to pay out of pocket for a nursing home, it's $10,000 a month. And if you can imagine people who think they're comfortable and they have a nice retirement savings, and then something bad happens and one of them have to go to a nursing home, that retirement savings will be wiped out.
Right.
Very quickly.
Right.
I want to point out that 70% of the nursing homes in the U.S. are for profit. And I really didn't realize that a couple of years ago. I was seeing a patient in-home visit, and the daughter told me that she worked at a nursing home, and this nursing home, which is in Taylor County, was for profit. And now every county around us, all the nursing homes are for profit. And It's very interesting how they operate. They don't make any money on the Medicaid patients. The only money they make are on rehab and Medicare patients, and then they occasionally have private pay. There are a few patients who still have insurance. If you want to try to go out and get long-term care insurance, it's almost impossible to find. The other interesting thing that they do, it's almost impossible to determine where their profit is, because they have different entities. Like, for example, one company may own the real estate, another company may be in charge of the nurses and food service, and another company may be in charge of the management. So all that money spread around, and you got to have a super accountant with many days of looking at it to figure out where the money's going and where the profit is.
And I believe quite a few of the nursing homes have been purchased by private equity groups.
Right.
Of course, they're all about profit. That's the whole bottom line, which leads to changes in staffing and other things to try to cut costs. So it's not a good situation as it is. But if the Medicaid funding goes away, it's going to be a problem for a lot of nursing homes. So.
Yeah, I think that number is private equity ownership is approximately 70 to 80%.
Yes, sir, that's correct.
Well, it's not just nursing homes. They're buying up clinical practices. They're buying up hospital systems. They're buying up hospitals. It's really scary that this is allowed to go on in this country, and the impact that it's had. There was a health system in Boston that literally collapsed because of the funding issues related to the private equity. But again, that's another thing for another time. Maybe I could get Amber and Barbara. My understanding is that Medicaid covers about 30,000 children, no, 30 million children in this country. And that's kind of, as a surgical oncologist, it's way off from my understanding of all that. I wonder if either one of you or both of you have got some thoughts about the impact of the defunding issue for the big beautiful bill is going to have on the access to health care for these 30 million children.
Well, yes, I'm extremely concerned because people that live in poor neighborhoods disproportionately suffer from health problems that are caused by a poor environment. The shelter in which I stayed for almost a year as I tried to rebuild my life, one of the things that we had to do going into it was sign forms that were hold harmless forms, which was because we had lead pipes and we had asbestos in our building. We had lead paint. So these are all things that are affecting children in these poor neighborhoods. The families live in older homes that still have asbestos. They do have lead paint on the walls. So, these children have, study after study shows that children in these kinds of poor neighborhoods have poor health outcomes as a result of their exposure to these things. So, whereas in a nice middle class, neighborhood, you're not going to have a lot of exposure maybe in a new home subdivision to asbestos. These children would have a lot of it and have chronic respiratory problems, was something that I saw a lot of when I lived in on the hill in Harrisburg. So, most of these children, almost without exception, are all dependent on Medicaid. If they do cut this, how are these children going to be treated? This is going to end up developing into, I believe, people with a lot shorter lifespans. These kids will not live as long. So it's a grave concern.
Barbara?
Yeah, the number is actually 36 million kids are under Medicaid. So that's a large number of children. And I would agree with Amber that the possibility or the probability that these children will have adverse outcomes as adults, even if they survive, is pretty significant. So again, I come back to the moral issue. We've talked about the extremes of age, the elderly people and the children, and what kind of society allows those people to actually languish and not have appropriate medical care. It doesn't make any sense to me. And I also agree that the legislators likely don't understand what that means. I've often said that people, if you're going to say the poverty level is $22,000 for an individual, have the legislators live on that amount for, I don't know, a month, 2 months, and see what that actually means, because I think that, you know, they really don't have any idea of walking in someone else's shoes in that respect.
Now, the economics of not providing this kind of preventive care for children, it doesn't add up. So if you have a child that has asthma and doesn't have an inhaler, what they end up doing is getting more and more, the condition gets worse. They end up in an emergency room getting treated for something that's more serious than the simple preventive care of having an inhaler and preventing that. And then the emergency room eventually will get paid for it, usually from Medicaid, but it costs more. And this goes back to the issue that surgeon, the retired surgeon who became a legislator, had told us. And the stuff that we're seeing, not just in the Kentucky legislature, but in the national legislature, just supports what he said 20 years ago.
Well, and I'd also like to add, you know, people don't think of what I call the ripple effect. So let's say that your child with asthma develops more problems, ends up in an ER, you know, they now have scarring or tissue damage, these kinds of things. It makes them so that they have difficulty breathing. Now, try to get that person a job. If you live in a poor neighborhood and you don't have access to higher education and you're not going to become a doctor or an engineer, you're looking at factory work where you're on your feet. You're working in a warehouse where you have to be moving constantly. You know, you're not going to be able to do those jobs if you can't breathe. You know, it's not like this person's going to be sitting at a desk. So, you know, now you've made it so this person is going to be permanently underemployed the rest of their lives. And I think that's one of the things that they just do not think about at all, is the long-term consequences of these things that they're doing.
Yes, that's a really good point. Go ahead, Gene.
I want to bring up another issue from the legislature standpoint, and I've had some tell me this. The Medicaid represents about a third of the budget in the state of Kentucky, and it's doubled in the last 10 years. And so most of the legislatures are really concerned about that. About 80% of that money comes from the federal government, about 20% from state government. So I got two questions: is how can we provide Medicaid services and still make a budget that's workable for the state of Kentucky? Is there any way to do that, or we just need to increase taxes, which they're not going to do?
No, well, one of the interesting things that I actually found, I was very curious about your question because, you know, I guess as a recipient, I don't think a lot about that specific issue. You know, I did find out that there was an auditor in September of 2025, the Kentucky auditor, Allison Ball. She released an examination that showed that there was $836 million that she could attribute to bureaucratic negligence. And it was interesting because when I started reading about some of the things, like, for example, the state of Kentucky continues to make payments for individuals for an average of 320 days after their deaths. Well, that's kind of a failure. And another failure was they were making duplicate payments. The state was paying managed care organizations for individuals who had already moved out of Kentucky and had moved to other places. And as I mentioned, I mean, being a poor person, you move a lot. I mean, I'm just being honest. You move a lot. And a lot of times it's out of state, either looking for work or because you can't afford to live in your circumstance. And so you have to go live with family or friends or whatever. And our state secretary, Dr. Stephen Stack, stated that the states lacked the necessary federal data tools to effectively identify concurrent enrollments in real time. You know, and this kind of ties back to all this new paperwork that they want. They can't already manage the paperwork that they have. They need to streamline the efficiency of this behemoth so that they're not dragging all this information around between departments and losing it and not able to find it, you know, so that they're making these double payments. I would be curious how much, and by the way, that 836 million was only over a 3-year period. 3 years, there was bureaucratic negligence, which resulted in 836 million. If you add another 200 million, there's $1 billion right there.
That's a good answer.
Wow.
Yeah, I was shocked when I saw that. You know, because I mean, I'm sorry, but you know, I feel like a lot of times people blame us. They blame the recipients, like, "Oh, I committed fraud. I did something." No, I didn't. You know, I mean, I literally at one point was experiencing chest pains, and I had a bike at the time. I biked to the ER, having a heart attack, so that I wouldn't have to charge people for an ambulance. You know, and I don't think I'm alone. I think most Medicaid recipients, we do try to be extremely, you know, conscious of what we are, you know, using as far as resources. And, you know, but I feel like we are disproportionately blamed for our health conditions. And, you know, in fact, when you look at the numbers, I mean, I assure you, there's not a bunch of poor people committing almost $1 billion in bureaucratic negligence. That's not us.
Well, you're dealing with a legislature that believes that they're they're trying to create a lot of fraud and abuse, which really doesn't exist in the system. This is again another example of a solution looking for a problem. Now, I want to give us a warning. This is the 5-minute warning. So, Gene, I'm going to ask you to maybe ask whatever kind of question you'd like to do that. And after that, I'm going to ask both Amber and Barbara to make a few comments, and then we're going to be running out of time.
Okay, well, I want to finish with how do you think we in the state of Kentucky and the nation, if we were living in an ideal world, we could solve this problem? You know, we're sponsored by Medicare for All. Would that solve the problem, or is there any other solution to our health care that could help solve this problem?
Amber, Barbara, go ahead.
Go ahead, Amber. Go ahead.
No, Barbara, go on. You started.
So what I was going to say is I've been a supporter of single-payer healthcare for a long time. And as a provider, as a physician, I can tell you that would simplify my life tremendously, not having to, you know, talk to different insurance companies and learn their formularies, et cetera. So I think that would make a huge difference. And it makes no sense to me. We spend so much money on overhead for insurance companies. Everybody talks about private insurance companies. Well, that's not a panacea. It's much more expensive. The administrative costs are much higher than Medicare. And also, as a provider, I can say that it's very frustrating to care for some patients with some insurance companies because you have to get prior approvals. You have to do all these things in order to get the care that you think you need for your patient. So I personally believe a cradle to grave insurance would be the way that, and most developed countries have done this. And why, I think the special interests of the insurance companies and pharmaceuticals, et cetera, have prevented us from moving forward with this. And it's really time. If we can spend $1 billion a day on a war that no one wanted, I hope that's not too political, then we should be able to afford single-payer health care.
Okay, Amber, your comments. We're getting close to the end of the lollipop here, so you
Oh,
kind of
yes.
have to make it
No,
brief.
I actually believe single payer is the win-win for everybody involved, because it would reduce the cost of overall health care due to the economies of scale. I think that it would help people like myself and the poor to have stable health care, and you're not going to constantly experience anxiety and fear over access. I think that it opens up employment opportunities for the poor, because then they don't have to worry about taking a job and possibly losing their benefits, or saving some extra money for their future and losing their benefits. And I think it would be a huge win for small businesses who struggle to hire and retain employees due to the inability to provide insurance. So I think it's a win-win for everybody, and that's what needs to happen.
Well, great. Thank you. I want to thank you both for coming on and talking about which I think is a very important subject. And I think this has been an excellent program because it has provided the views of Medicaid and the issue of the defunding of Medicaid from the perspective of a recipient and a provider. And I hope that these issues are penetrating the brains of the voters. The legislators aren't listening to this, so I don't know that you can do much about them except not put them in office. So thank you both. And Paul, you want to make any comments to take us out?
Yeah, I would like to circle back to this work requirement issue for Medicaid recipients. The current facts are that nearly 2/3 of Medicaid recipients are working, either part-time or full-time. 42% of them are actually working full-time. So there's just so much misinformation out there that tends to skew public perception of Medicaid and welfare recipients in general.
Okay, I guess that's it. Are we still recording?
We've got another minute, but anybody got any pertinent remarks? Let's get them in right now.
I would like to see the legislature quit giving tax breaks for, or funding small business tax credits, Kentucky Enterprise Initiative Act, Kentucky Business Investment Programs. They can do all of this, but if they would actually do something to actually fund employers or incentivize employers to give insurance, I'll tell you what, the 50% of people who are already working while receiving Medicaid would then have private insurance.
Thank you, Amber, for an excellent parting comment. And thanks to everyone else who participated in today's show, and a special thanks to our listeners out there for tuning in. Join us next time for Single Payer Radio. This is Paul Hoppy wishing you a wonderful rest of your day.